Privileged to chair the Sax Institute board. I begin today by acknowledging the traditional custodians of the various lands on which you all work, and I pay my respects to their elders past, present and emerging. In my case, it's the Kaurna people of the Adelaide Plains. I extend that respect to any Aboriginal and Torres Strait Islanders who are meeting with us today. I'd also like to welcome our Sax members, and I thank you for joining us for our first Sax Forum on the important topic of emerging technologies that will impact on the use of evidence in health decision making. And we're very pleased with the number of people that have signed up for this. A couple of housekeeping matters. Please use the chat function for questions, and we'll deal with the questions at the conclusion of the three talks. And please note that the meeting is being recorded. So I'd now like to hand over to the CEO of the Sax Institute, Martin McNamara, to introduce the speakers. Thanks, Martin.
Yeah, thanks very much, Ian, and great to have you all join us today. The Sax Forum is a really important event for us at the Institute. We do thank you for joining us today, and a particular thank you to all the speakers who have volunteered their time as well. We see this as a really important event because it does bring our members together. We've now got 74 members across the country and growing, actually, and the Sax Forum is a really important opportunity for us to find ways to collaborate with that membership network. We see this as really important to do things like exchange, share knowledge, promote connections amongst our members and promote collaboration. But also we hope generate some wide-ranging discussions. So we spent some time in the last few months thinking through what might be of broad interest to members, and we've got some feedback from our members about the topics that interest them the most, and that's generated the agenda that we've got today. So I am really looking forward to each of the presenters sharing with you their thoughts on this important topic. So to move on to introducing each of the speakers today, they're all really impressive people and leaders in their own fields, and it's very hard to cover off on their biographies in a brief way, but I'll try and do the best I can on that. So firstly, we've got Professor Trish Greenhalgh from the University of Oxford, and Trish would be well known to many of you. She has spent a lot of time interacting with the Australian population over the years in her careers. She's internationally recognised as an academic in primary healthcare and is trained as a GP. She's the co-director of the Interdisciplinary Research in Health Services Unit at the University of Oxford. And she has a program of research at the interface between social science and medicine, with a strong emphasis on things like the organisation and delivery of health services. So many of you would have seen some of her work in relation to the COVID-19 pandemic, where she brought that interdisciplinary perspective on the research response. And Trish has been awarded an OBE for services to medicine in 2001 and was made a fellow of the UK Academy of Medical Sciences in 2014. So really impressive and great to have you join us today, Trish, at the slightly earlier time of, I think, around 5 a.m. in the UK, or maybe 6 a.m. now. So thanks for joining us, Trish. So the second speaker, I'll go through all the speakers and throw to you, Trish, to kick us off. So the second speaker will be Professor Julian Elliott from Monash University in Victoria. So again, I'm sure many of you have heard of Julian's work. Julian is one of the world's leading researchers in the use of technology for evidence synthesis. He developed the living evidence model, which is a high quality systematic review method that keeps those reviews up to date with the latest research. He was the founding chair of the Australian Living Evidence Consortium and established the COVID-19 Clinical Evidence Task Force. Both of these initiatives were based at Cochrane, Australia, within Monash University. And he was also the recipient of the Australian Health Minister's Award for Excellence in Health and Medical Research. So fantastic to have you here, Julian, and really appreciate your time. We've also got Professor Bronwyn Hemsley, who's from the University of Technology in Sydney, where Bronwyn is the head of speech pathology. Bronwyn's a fellow of Speech Pathology Australia and a fellow of the International Society for Speech Pathologists. Bronwyn has developed a comprehensive program of research relating to communication, swallowing, social media, and advanced assistive technologies, including VR and generative AI. Really looking forward to hearing Bronwyn speak today. She's also been awarded the Dean's Award for Research Excellence at the University of Newcastle, and numerous acknowledgements for her research impact over the years. So thanks to all the speakers for giving up their time today. I will now throw to Trish to kick us off. And just a reminder that if you do have some questions, please enter them in the chat and we'll get to them at the end of the speakers session. So over to you, Trish. Thanks very much.
Well, thanks very much. Can someone just confirm that you can hear me okay?
Yes, we can. Yeah.
Fantastic. So the title that I was asked to talk about was New Frontiers in Evidence Generation, what it means for policy and practice. I guess that's in a way what we're all talking about, but I'm going to give a very personal account of how I discovered some new frontiers. Let me take you back to the 8th of March 2020. There was a beautiful rendering of Bach's St. John Passion in one of the concert halls in Amsterdam. And very sadly, that lovely Easter performance of the St. John Passion led to 102 members of the choir becoming infected, and 4 people died. One of the members of the choir and the spouses, the husbands or wives of 3 other members. The conductor ended up on intensive care. And this was at the time when really in the West, we hadn't really picked up on how terrible this pandemic was going to be. But I remember thinking at that time, only airborne spread could explain this. Something was happening with singing. It couldn't possibly be that everybody in that choir touched the same doorknob or shared the same salad fork or something like that. It was one of the first super spreader events. 3 days later, 11th of March 2020, my birthday as it happened, the Director General of the WHO, as we all know, declared the pandemic. Now, less than a week later, some colleagues and I submitted a paper to the British Medical Journal, which was actually published a couple of weeks later, very early April, arguing that really there was some very strong arguments for universal masking in public places, in indoor places, using the precautionary principle, using the common sense principle that, look, if it is airborne, wearing a mask would be a good idea and would prevent a lot of deaths and prevent the pandemic from becoming catastrophic. That was pretty much ignored in the early years. The other thing I just want to throw in is that towards the end of 2020, my own mother died of hospital-acquired COVID-19 in a hospital where masking was only happening close to patients with known COVID or suspected COVID, but the air that people were breathing in and out was absolutely suffused with viral particles, and the in-hospital infection rate was 50%, 50, 1 in 2 people who were admitted to hospital with anything. My mother went in with a broken leg, they got COVID, and many of the elderly and frail people died. Now, why was I so sure that this was airborne? Well, I wasn't sure, but this was a hypothesis that was forming in my mind very early on. And I want to take you to a quote from Sir Peter Medawar, Nobel Prize-winning immunologist, as you may know, but also philosopher of science. And in a little monograph called Induction and Intuition in Scientific Thought, which he published in 1969, he said this lovely quote: "Scientists need to do more than browse over the field of nature like cows at pasture, just sort of chomping on the evidence." He said the initiative for scientific action comes not from the apprehension of facts, but from an imaginative preconception of what might be true. This might be airborne, and if it is airborne, this is what follows. Now, I want to take you away from COVID for a minute, and I've coloured these slides green so that we're not talking about COVID anymore. We're talking about cholera. and I did a paper here drawing some parallels between what went on in cholera science a couple of hundred years ago and what was going on in COVID science now. By the way, I've got some QR codes. I've got them all on a slide at the end for papers if you want to look them up. So, as you may know, and certainly most people in UK know because they go and visit this pump, John Snow, public health physician in London, took a look at the cholera epidemic and very famously worked out that it was spread by infected water, removed the handle from the pump and stopped the outbreak. Let's just unpack that a little bit more. Edwin Chadwick, who was a pretty good guy, he was a social entrepreneur. He really cared, but he had the wrong theory. He propagated a miasma theory of cholera. It was spread by foul air, the smell of sewage, and the data that was collected in the mid-1800s to inform the science of cholera spread was this kind of data. The weather conditions, the temperature and the humidity of the air, what the air smelt like. This was very systematically recorded. The elevation of the land, because the miasma was believed to stay very low to the ground. Whether houses looked clean or smelt clean, and whether the containers used for water were clean. Well, that's all very well, but if that's the data you collect, that's the data you're going to analyse, and your findings are going to relate to that kind of data. John Snow and his partner Henry Whitehead actually added another question to the weekly statistical returns for public health in 1853, and it was less than a year later that they've clearly demonstrated that people who got their water from that pump were being infected and people who got their water from somewhere else weren't. It was very clearly demonstrated, but until someone imaginatively thought, hang on a minute, maybe it's in the water, they weren't collecting the right data. And yet, a year later, the National Board of Health report on the Soho cholera epidemic in 1855 said, after careful inquiry, we see no reason to adopt this belief, the belief that cholera was waterborne, even though they had the evidence in front of them. We do not find it established that the water was contaminated in the manner alleged, nor is there before us any sufficient evidence, etc., which is quite extraordinary when you look back, knowing what we know now, that they were still adherent to the idea that cholera spreads predominantly or exclusively through the air. Well, come back to COVID-19. Something very similar happened. Now, we published a paper in 2022 in the BMJ summarising the narratives, the stories that were being told about how COVID spreads. And the WHO, as you probably know, was putting out a narrative right from the beginning. It's spread by droplets, wash your hands. And yet, there was another narrative coming from aerosol scientists saying there's a lot of evidence that it spreads via the air. But WHO continued, and even to this day, some people in WHO are continuing to say, just keep washing your hands. It's the most important thing. And this flawed narrative has been incredibly difficult to shift. Diani Lewis wrote this lovely piece in Nature, published it in 2022, why the WHO took 2 years to say COVID is airborne, even though in July 2020, 237 leading aerosol scientists offered to help the WHO, saying there was overwhelming evidence of airborne transmission, and they didn't even get a reply to their letter. So what's going on here? We all know this picture, I think, the hierarchy of evidence within evidence-based medicine. I've been involved in generating this hierarchy. I've been around that long. It's probably 30 years old now. I was around sitting at the feet of Dave Sackett, all that kind of thing as a young researcher. Jonathan Fuller calls it the measurement framework, and I really like that. I'm going to borrow his terminology. And the assumptions here are that the purpose of science is to measure an intervention's effect, that there is a hierarchy of evidence. And the reason why randomized controlled trials are at the top is because these measure the effects of interventions with the least bias. Obviously, they can still be biased, and we have those risk of bias tools. But the aim of evidence synthesis in this paradigm is to sift out the high quality measurements of effect from the low quality measurements, and then sum the high quality ones and reject the low quality ones. All sounds pretty good, yeah? And this is the kind of stuff that comes out of that paradigm. The Centre for Evidence-Based Medicine, actually also in my university, was very clear right from the beginning that there wasn't any evidence for the efficacies of masks. They'd taken that top red triangle, just the peak of the pyramid. They wanted randomized trials and systematic reviews of randomized trials. And actually, they're still doing it. There's a Cochrane review that came out at the beginning of 2023, no firm evidence that masks work. And as you probably know, this caused all sorts of controversies because the press picked it up, etc., etc. Because actually, if masks don't work, that has huge implications for the next pandemic. Never mind the one that we're still trying to kind of get through to the end of. I wasn't happy with this. In 2020, I wrote the first paper, sort of preliminary paper, asking, will COVID-19 be evidence-based medicine's nemesis? In other words, is this going to be the end of EBM? Because EBM is taking this really very rigid view about RCT evidence in complex situations when actually that pyramid of evidence didn't seem to apply. And then along with some colleagues, several from Australia actually, I published this paper a bit later, I think in 2023, called Adapt or Die, meaning EBM has got to adapt or die. It's just going to become so irrelevant. And I talked about something called EBM Plus. That's not my terminology. I can't remember who came up with it. But it's the idea that we need more than the pyramid of evidence, or we need to use that pyramid of evidence, hierarchy of evidence, in a different way. So EBM Plus is needed in particular for complex questions where causality is key, like the question of how does SARS-CoV-2 spread, because then we can design our complex interventions around that mechanism. And what EBM Plus says is there's no universally applicable hierarchy of evidence, although of course, if we're asking if an intervention has an effect, an RCT is usually preferred for all the reasons I'm sure you know. Good science, says EBM Plus, needs multiple methods applied adaptively and pragmatically to build a nuanced narrative which explains all the data. We have to explain why all those choir members got sick on the 8th of March during that singing performance. We can't just say randomized trials are the only thing we have to look at. EBM Plus says that theory and explanation, causal explanation, is at least as important as method, and the overall narrative needs to make sense and be plausible. Common sense comes into this mix. And Jonathan Fuller and his colleagues call this the argument framework. You have to craft an argument rather than just measure things. So argument evidence, the evidence that goes into the mix for the argument around masks is many, such as laboratory experiments where they light up people's coughs and sneezes and see the drops and going all over the place. Actually, case studies of other choirs where people have got sick, and these have been done very meticulously and systematically. More argument evidence, natural experiments of masking. Up on the vertical axis is deaths from COVID in the first 100 days after the first case in the country. And you can see that countries that didn't mask in the first few days or few weeks had exponentially more deaths than those that did. And then the ferret experiments. Here's another bit of the argument. How do you explain how the ferret in the uninfected cage became infected when the only thing connecting those cages was an air duct that went round lots of angles? You simply cannot explain those findings without invoking airborne spread. So I love this paper. It's been published in Nature Medicine quite recently. I'd strongly recommend you take a look at it. These are philosophers of science, and what they say is an argument framework grounded in the science of reasoning provides an alternative to medicine's measurement framework, the EBM framework, for evaluating and synthesizing evidence in healthcare. And I won't flog this too much because I've only got a short time slot. But if you look at the red circles, you can see that in the measurement framework, the main tool for evidence synthesis is meta-analysis. But in the argument framework, it is a synthesis of arguments. And they actually do this philosophically using analytic philosophy, and the blue things are different, but the blue nodes in this nodal diagram are pieces of evidence, and then the pink ones are statements. You've got a brown dot there, which is mathematical modeling, and you can see at the bottom what you produce here is actually a hypothesis that community asymptomatic mask wearing substantially reduces the incidence of this infection. Now, that's a hypothesis which seems to be borne out by the evidence, and then you can test it and you can refine it. And I'm in correspondence actually with Jonathan Fuller because he used our mask papers as a sort of worked example in his philosophical paper, and hopefully we're going to refine this because this is roughly sketched out, but to drill down into that is going to take quite a lot of time. Unfortunately, I've just got a grant to do it. Just one more thing to flag. We actually did produce a new argument-driven review of masks. We were commissioned to do that by Clinical Microbiology Reviews, but we haven't yet applied Jonathan's argument framework to it. I'm also working with John Williamson from University of Kent, who is going to do some Bayesian mathematics on this. And so I'll report back when we've done that. So here are some QR codes if you'd like to quickly take a picture of that. Those are mostly the papers of mine that I've been referring to. I've also put the ferret paper in because I thought you might like that, and Diani Lewis's paper about WHO. And now I'm not going to give you that because that's one I decided not to give you. Just to thank my funders, all these people and probably more. And I'm now going to thank you for your attention and stop sharing.
Thanks very much, Trish. Fantastic, and great to see that ferrets have got a role here. Fantastic case study, really bringing to life the potential of EBM Plus. Really appreciate that. So we might move on to Julian next. And Julian, are you ready to present? Yeah, fantastic. Thanks, Julian.
That's great. Thanks, Martin. So again, can I just check that everyone can hear me?
Yes, we can. Yes.
That's great. All right. So I'm in Vanuatu at the moment, and the internet is reasonably good, but please shout out if I'm not coming through clearly. What I want to talk about today is living evidence, and thanks to everyone for the invitation. I think it very much builds on what Trish has been talking about. So maybe just to kind of make that clear, I think the context, just some couple of case examples, the context of producing using evidence in decision making, both public policy and in practice settings, I think it's in a different era. Part of this is the scale and the multitude of crises that we face. So here's one example, of course, perhaps the most dramatic, how the world responds to the climate crisis. So obviously science has made an incredibly important contribution to understanding that the climate is changing and the causes of that. But particularly when we're thinking now about how we mitigate those changes, prevent, mitigate, and adapt, we're in an era now where we need to bring a whole range of scientific evidence to bear and not only make sense of that in rigorous ways, but also, of course, think very carefully about the way that that is actually intersecting with communities, with governments, with decision makers generally around the world. So we are in a different era. And I would argue essentially along the same lines as Trish that a lot of our evidence systems are really not in a new era. They are stuck in a more of a 20th century paradigm. And just to give you another example closer to home, and you know, this is just an example, of course, you know, the standard approaches that we all use every day. So, you know, this was a very important policy window when South Australia commissioned Julia Gillard to lead a Royal Commission into early childhood education and care. Of course, quite a substantial investment. So when we think about that as a policy window, and the way that all that is known about early childhood education and care can be brought to bear into the deliberations, the recommendations, and of course, the government decision making, you know, I think we have to recognize that I think those pathways that capture the kind of complexity of research evidence that we have available to date, you know, is been quite limited. And so as an example, within this program, there was a rapid review commissioned that had about a month to pull together all of the research relevant to some of the most important questions of the commission. And of course, at the same time, there'd be many, many groups around the world who are also looking at the same evidence. And the next month, of course, many other groups looking at that evidence. So, you know, a lot of our evidence systems, I think, are very fragmented. There's an enormous amount of duplication waste. And COVID has been a great example of that. In many, many questions, there were more systematic reviews than there were primary research studies. So we have an evidence system that is built for a context in which we had fewer groups doing evidence synthesis, fewer studies to review, and we're more able to kind of make sense of the science. But we're now in a very different world where we have a lot more complexity. And again, a point that really builds on what Trish is saying, I've been involved in a group called the Global Evidence Commission, and you know, one of the kind of key points we're trying to make through that work is that we're really in a world now where we have very, very diverse forms of research and data. And we need to think very carefully about building systems that can draw on that diversity to answer these complex questions that we're now dealing with. So different types of questions require different forms of evidence. And both those who are involved in pulling together data and research evidence, and I think particularly those who are working in intermediary or brokering roles, I think have a really important role in building the capacity around decision makers at scale to be able to effectively, efficiently, and very quickly make use of these diverse forms of data and evidence. But just to hone down a little bit on evidence synthesis, Trisha's really already introduced this. I mean, the whole endeavor of evidence synthesis was a response to the ongoing growth of research and essentially trying to create some sort of sense of that science to inform decision making. It's of course a very rigorous process. It continues to evolve. Trish, of course, has been one of the great advocates for ongoing evolution in that science. But one of the key issues is really we've got enormously well-developed methods, but the systems that we have to support that work are not keeping up. So as science accelerates, as the amount of research that is available for decision making increases, we don't have systems that can move at the speed they need to. So this figure is from some Cochrane data, but it's really indicative of a broader problem that producing rigorous summaries of evidence just takes an enormous amount of time. And that's even when you restrict to you know, the more traditional studies. When you have a view, when you want to look more broadly into a whole range of studies, then of course that adds to complexity and also adds to this challenge. And so I would argue that what that does is create a vacuum where those, well-considered, well-put-together pieces of research synthesis can't keep up with the science. Then, of course, what do decision makers do? They have a choice between forms of evidence that are out of date, or perhaps rigorous and out of date, or try to get some sense of what the latest science is saying. So through a range of methods, of course, talking to experts, social media, traditional media, doing some quick literature searches, etc. But we know that those methods are really not a solid foundation for effective evidence-informed decision-making. And so that trade-off is really a key barrier to the effective use of research evidence in policy and practice. And I just want to note that it's not just practice and policy that's suffering here. Science itself is suffering from information overload. So this is just a couple of papers showing that counterintuitively, the most prolific research fields are the most stagnant. They have the least turnover in the highly cited papers. And you can think of many hypotheses for this, but really I think the most compelling is that scientists themselves find it difficult to navigate and keep up with the latest publications in their own fields. Similarly, research papers and patents have been shown to be using a narrower and more out-of-date fraction of knowledge. So, these issues around how we make sense of very large, fast-moving and complex sets of research and data impact our society through practice and policy, but also directly in the scientific endeavor itself. So this approach we call living evidence very simply just tries to break that trade-off and create useful summaries of research and data that can be kept up to date with the rapid flow of new research. So it breaks that trade-off between what I think of as fidelity, some sort of representation of the underlying research in whatever field, whatever range of sources, whatever degree of complexity, that kind of bringing that fidelity and the currency together. And so in the Global Evidence Commission, in some of the work that we're doing, calling for some enhancement and leverage of the global evidence architecture, we're talking about investing more in this living evidence approach to ultimately to create better forms of evidence for decision making. And just briefly, the way this works is if you think of conventional models, conventional approaches to producing any form of evidence or guideline or policy brief, these are traditionally kind of intermittent processes. We go through the work of defining what scope we're going to cover, developing whatever evidence product it is, say approvals, publications, etc., and then we stop. And of course, because research continues, you therefore have this decay in the accuracy of that resource, therefore its reliability, therefore I would argue its utility, and therefore our return on investment into that work. Until at some point, of course, where there might be a decision based on stakeholder need in order to update that resource. And so once again, we have to climb the mountain. And, for anyone involved in these updates, you often hear the phrase, it was almost as much work as the original project. So in a living evidence approach, very simply what we're doing is the initial work of getting to an up-to-date resource is exactly the same. But instead of stopping work at that point, we move then quickly into what we call living mode. So essentially what this is very tight cycles of search, incorporating new research into the synthesis or whatever form of summary or product you have, and then continuing those cycles over time. So it's, of course, not no work, but it's work that is more evenly distributed over time. And so this is why we call it kind of walking along the plateau. And most groups that have been involved in this find it kind of surprisingly feasible to do this work and to add further projects on top, because the predictability and the kind of stability of the volume of work. So this approach we've been working on for a number of years. There are now many groups around the world using this approach to produce and use evidence. We were also very involved in the COVID response here in Australia and use the living evidence approach really to address some of the issues that Trish was talking about in terms of the kind of cacophony of voices. And what we did through that work was bring together a consortium of groups from across the country, many different, very diverse set of peak health bodies, essentially to work together to understand the evidence at speed using a very diverse range of sources and create some sort of coherent messages, both in practice and policy. And so through this and some previous work, really what we've shown is, if you think about the time from the publication of an original article through the publication of some sort of evidence output, we've shown that we can dramatically reduce that time lag. So this is essentially a 99% reduction from producing some sort of evidence output, say every few years or so, down to every week or 2 weeks or so. So we've definitely shown the living evidence approach is feasible. It provides clarity in very complex research fields and can move, at speed when needed. We've also shown how it can improve the engagement of decision makers and build cross-sectoral alignment for coordinated action. And so now living evidence is being used in a range of settings, not only in health, but also in education, in climate, in many different groups. And also, I think just to note, this is, using, again, a very wide range of primary evidence sources, including mechanistic studies, laboratory studies, preclinical animal studies. There's really no limit to the kind of sources that could be used using this model. But I think really one of the key learnings we've had particularly in recent years, is that, although we started this journey thinking about essentially a better evidence product, how can we create evidence outputs that are both rigorous and up to date? I think what we've really learned is this is very much about shifting to a very different mode of producing and using evidence, where it becomes a conversation. So it becomes a way that those who are involved in bringing research and data together can work very closely with decision makers and respond in near real time to their decision-making needs. And so then that becomes, as their decisions evolve, their contexts evolve, their questions evolve, you can have a system that supports decision makers in a much more responsive way and kind of follow them, go with them as they move, as those contexts change. And so in some ways, this is really about creating, a model that we've represented here, where we're kind of working in these constant cycles, where practice is constantly informing the questions and the synthesis work, and that synthesis work is constantly informing the understanding of research and therefore action. And so together with others, we've recently formed this alliance called the Alliance for Living Evidence, where we've got a number of projects now really looking at how we can optimize this so that ultimately we have an evidence system that is much more responsive to the needs of decision makers and builds a real partnership with them in a way that really creates an engagement throughout the evidence production and use cycle. So I'm now going to shift gears a little, given the topic and interests of Martin and others. So just to talk a little bit about the technologies. So technology, software, AI, machine learning, all of these things are not necessary for taking a living evidence approach, but they are important enablers. And so we're obviously in a time where AI is very topical. So just to talk a little bit about how I see this playing out in the kind of world of evidence. So first of all, just probably most of you know this already, but just to kind of set the scene with some definitions. So AI, very unhelpfully, is often defined as the intelligence of machines. In essence, it's a field of computer science that is concerned with the broad set of goals that we understand as intelligence. And so there are many different approaches to AI, but one of them is what's called machine learning. And that is the approach that is really dominant at the moment. And that's because of the development of what are called neural networks, which are essentially computer systems that are built to model the neurons in a brain. And there's a particular approach to neural networks called deep learning, where there are many, many different layers, as shown in this diagram. And that's been really the game changer in this world. And then using those approaches, there's been this advent of generative AI, which of course has led then to GPT, ChatGPT, and of course a lot of the excitement. So just to note that, of course, like any of these new technological frontiers, there is a lot of hype. But underneath the hype, there is a lot of reality. This is an absolute step change in technology and will have profound implications, of course. And this is just a representation of this. So showing, how many of these systems now are reaching human level performance. There are, of course, still many, many significant gaps. But I think also what's really noteworthy in this chart is just notice the slope of those lines. So it's not just that these systems are now reaching human performance, but it's also that the development of these systems is now really accelerating. So, what's the relevance of AI to evidence and evidence synthesis? So just the first point I want to make is that it's already being used in evidence synthesis systems. So, we use it in our products and many others do. These are some of the systems that we've developed with collaborators at UCL, James Thomas and others. So they've been embedded in those kind of systems for many years. But of course, the advent of these more powerful systems will have very profound implications. And, just very briefly, I think of this in kind of two categories. So first of all, this kind of generative AI is really the newest form of kind of quick and dirty evidence. You can think of this as analogous to the way that people could use Google search or Wikipedia when they're trying to find research and evidence in order to inform their decisions. We're going to see an absolute explosion of these kind of products. We're already seeing that now. And some of them, of course, are general purpose, like ChatGPT, but there are many, many, many that will be very focused on evidence-informed decision-making. And of course, the reality is that there will be a lot of snake oil. There will be a lot of overstating claims. And of course, the rigorous evaluation of those systems will lag significantly. And so the challenges will really be around accuracy, bias, transparency, explainability. But I think as a sector, of organizations, individuals that are interested in the way that research evidence is used in decision making, I think we do actually have an opportunity to try and create some very clear articulation of what sort of performance we need from these systems. So that window will close at some point, but we have an opportunity, I think, to shape this market through some very strong statements. So that's perhaps some of the risks or messiness that's going to occur. But at the same time, I think there'll be very significant benefits from these technologies. So not so much through the conversational AI, but the underlying technologies, what's called the large language models, are really going to accelerate the automation of evidence synthesis. So that will, I think, accelerate the adoption of living evidence. There will be similar challenges that need to be addressed. And in a very analogous way, I think we also have an important role, an important opportunity now to define the performance requirements that we need for safe and reliable use of these AI systems within evidence synthesis. So I'll just close there and say that we are in a different time. The scale of the problems and the policy-making environment that we're in, I think, is now different to how it's been in the past. The range of research that we need to bring to bear is different. But we also have new approaches that I think can help us achieve something like this, providing communities, organizations, and governments with evidence systems that are truly responsive to their needs, which I don't think we've really achieved to date. And then ultimately, of course, are about not evidence per se, but creating the conditions for effective action and better outcomes. I'll stop there. Thanks very much.
Thanks, Julian. Fantastic presentation and really great graphics going along with the story of how rapidly things are able to be done now with those living evidence models. So thank you for that. We might hand over to Bronwyn now. And just a reminder that if you do have some questions, please do put them in the chat. Okay, over to you, Bronwyn. Thank you.
Okay, I'm just getting my slides lined up. Okay, so thank you very much for the invitation to speak at the forum today. And I guess I've really been fascinated by the two presentations I've heard just now. I'm actually in Newcastle today, so I'd like to acknowledge the Pambalong clan of the Awabakal people, as well as the people of the Gadigal lands where UTS stands in Sydney, and all the Indigenous people of the lands where you're attending from today. So I guess my talk is a little bit applied in the applied direction. I'm a speech pathologist. I work in assistive technology. And so when generative AI and all the OpenAI ChatGPT was released, it was obvious that this might enhance and increase the rate of communication for people with no speech. So it was immediately of interest to me as a speech pathologist, but also in terms of disability access and inclusion, that another advancement in digital technology shouldn't leave people behind and should actually help to address some of the issues that people already encounter with barriers to inclusion related to poor information access and not having, I guess, the ability to reach the information, much less put it together and apply it in their own lives. So I'm going to provide you with some case examples in my field of communication disability and mealtime management. And you'll see it does provide some examples from what Julian and Trish have presented. I also co-lead a network at UTS, which has formed of health professionals across many disciplines responding to generative AI, and all really feeling that we have that sense of needing to catch up and keep up with rapid advancements in the technology. So one of the important things I think that health professionals need is a community of practice. Anyone can join this one where we meet once a month for an hour and just simply discuss and try and critique the new technologies that are arriving every week. And the idea is that we can be engaged in co-design of these technologies so that they are evidence-based, so that they are useful to everyone who might benefit from them. So in doing so, in adopting generative AI in, say, speech pathology or an allied health profession, I would say some of it is not new. We've been there with a lot of digital health systems. So what we've learned already about, for example, e-health records, social media as a digital technology in relation to evidence, the use of speech communication aids and voice synthesis, speech devices, we can look back on what we know from those studies and from that practical usage and predict a bit the types of supports that we're going to need or what we need to keep in mind to improve the design of generative AI if it's going to be useful. So first I'll cover off a little bit about we need to have ethical AI and we need to be involved in the co-design of ethical AI. We need it to be safe, effective, enjoyable and efficient and enhance our work as health professionals, and we need to support clients to have that access as well. I'll give you an example of where I did use a conversational interface with the latest version of ChatGPT 4 because it provided that leap from text-based interaction into a conversation with my phone and software on my phone that was a person answering conversational questions that I had about an example of a treatment that I thought, well, I'll see what this conversation is like, what I learned from ChatGPT 4. So I'll present a bit of info on that. I'll show you some examples of how generative AI can be used to enhance therapy for resource development and use in sessions to increase the productivity of, for example, people working with in speech therapy domains, and also give you some examples of AI, which are quite exciting and which will help drive forward the field. So there's lots and lots of resources around ethics and governance of AI now, which is great to see. After 12 months, there's a boom in this area. I won't go into all of these things, but that's a really important knowledge area for health professionals to keep up and catch up and keep up with these types of guidance and frameworks, which will be really helpful and should be applied as they adopt AI. Nonetheless, there's a lot of dangers, risks, ethical issues and ethical problems. For example, just this week, reports of the use of photographs of children with personal details provided without consent to train AI, and, a whole lot of issues around that. So it is something to keep in mind. Should we be using photos, pictures from AI, knowing this? That's an ethical decision. So we'll be constantly faced with issues around the ethics of what's coming out. What are they trained on and what's coming out? And Julian touched on some of those aspects of bias and equity, which are real problems. Other things to keep in mind is that generative AI is expected to accelerate and massively amplify some of the downsides of social media, for example, the use of deep fakes with computer vision and imagery, enhancing people's ability to do massive campaigns of misinformation. And because it's creating what's called plausible bullshit, in that if it doesn't know the answer, it will create an answer that looks plausible, and it could be close, but it's made up, the answer. So that type of level of accuracy and credibility of the information and the trustworthiness of information as well is going to be really important. But it will drive content creation for other platforms like blogs and podcasts and YouTube videos, Instagram posts, TikTok, etc. So we'll have lots of content that may or may not be accurate or based on the latest qualitative or quantitative evidence that's coming out from health professionals. So I think we will have to be involved and be using it, be engaged with it, so that we can counter some of these things. Just as I always recommended health professionals be in the social media space to know what's going on in that area, even though there are risks associated with that. So I'll just give you an example based on a study that, an area that we're doing now, which is a systematic review, which had very broad inclusion criteria. We were not looking for randomized control trials, knowing that there aren't any, but we were looking for any treatment studies that would address a very, very popular, relatively new treatment called Gestalt language processing interventions for children or adults with communication disability. So I thought I'll take this idea to ChatGPT-4 with my mobile phone, have a conversation and see how it performs in comparison to what I know about Gestalt language processing, and wondering if it has any kind of bias towards the information that it found, that has been trained on. Is it innocuous, as in do no harm type of things? Does it strive to be equivocal about the misinformation or the disinformation and the evidence? And is it going to be obligingly providing the bullshit that's already freely available and plentiful online? So this is a treatment where there are thousands of Facebook members, lots of groups, hundreds of podcasts. There's a proliferation of information at the anecdotal evidence level. So I started a conversation. This was in talking, not in typing. And it was quite a friendly, congenial kind of interaction with the device, which is a good usability feature. And it gave a fairly good, simple introduction to defining what this treatment is. So then it asked me, have I got any specific aspects? So it was a good questioning interaction. I do know that there's quite a weak theoretical foundation to it, so I threw that into the conversation. And yes, it agreed. It then agrees with me along the way. It's a common critique. So not something it mentioned first up, but ask another question and it's admitting it. And then saying the theoretical foundation isn't as strong, where I might have said it isn't strong. So it's still fairly on a par with what I might say to somebody. On the other hand, it's then sending in the reported positive outcomes, which are plentiful on the internet. So I thought, okay, it's going along, and I thought I'll ask for more specific outcomes. So yes, it will provide the same claims that are freely floating around the internet, shared widely on social media, by the developer, by other groups. And then I think that where its incorrect information came was when it was saying it's based on anecdotal reports and case studies. So that's incorrect. There weren't any case studies that we could find, published or unpublished, that showed the treatment being delivered and outcomes. So our systematic review that we've been developing has found no studies of any design that would measure the treatment or understand what's in the treatment or even outline the types of activities that are being used in the treatment. So it's sort of going into that area now of really repeating what it's been trained on, which is all these claims, but adding in some incorrect information. So I went back. There's no case studies. They're all anecdotal evidence. Is that right? Yes, that's correct. So why do I need to know the answer to get the answer to come out? It's noting there's a lack of published, but also there's a lack of unpublished. It's noting there's no large-scale studies, but there aren't any studies. So it's still sort of hedging on the positive side towards the views of the majority and what's popular. So I thought, let's see if it can find our systematic review protocol. And it searched for sites, which I think that's great because it is going out to the other sites, and perhaps it will find things that it's directed to go and find. So it did find it and pointed out the goal correctly, and then 2 more paragraphs about the claims of the treatment, and also saying that there's ongoing research when really there's no evidence of that. So I think that's an interesting example of how if experts or people that know about the literature and know about the studies and the theory should engage with these generative AI systems to try and understand how do they work and what kind of prompts might help parents, teachers and others to get drilled down into what's the other information that might be less plentiful but still important. Okay, so the second example I'm going to talk to you about is where, if you think about all the domains of, say, speech pathology in this case, there's lots of areas where it could be helpful to enhance our services for either screening, assessment or therapy. One of these areas that I'll show you an example of is using visual supports for learning language in autism. Of course, there's lots of other areas with deep learning and with large language models. These are really well suited to communication domains. So it's performing better each time we try it over the last 12 months with narrative and oral storytelling development. So it's knowing more about how to pick words that we want to use in our treatments, being able to pick up parameters of people's voice, so being able to hear the voice of a speaker and analyse it, so that's getting better. Being able to look at video fluoroscopy of swallowing, so to detect changes in people's swallowing and help the clinicians to identify what's going on in the swallow. all sorts of areas, as you can see, almost every area in, I guess, in speech pathology at least, we can see some potential for there to be enhancement with the use of generative AI. So this is just an example, and I'll talk you through what's on the screen. We do use lots of software already to create visual supports for learning language or talking about vocabulary and messages for people who are unable to speak or have trouble understanding language. So I thought I'll show you a comparison of how far generative AI really has to go in terms of the images. So I asked it to create a picture of 3 squares by 4 squares in a grid, because the grid pattern is sometimes something that helps people be able to talk about those topics. So related to eating food, it really got stuck on knives and forks, beer and hamburgers and chips. So it didn't really do the job. I could have done a much better job with prompting it, but it's really up to me to do the prompt engineering on the images. The next one was to try and be a bit more specific for them and tell ChatGPT-4 to make the 12 items and give them a number of the items, and please give me 3 other fruits as well. So overall, it gave me 10 different fruits, and it sort of perseverated a bit on pineapple and bananas, but it's better than the first one. So compare it to the one on the right, which is what I can currently do with software in less time that it takes to actually create a grid of pictures, which is what I was after, of 12 different fruits. So we can already see that we know where we want to be. How can we get the image generation and the prompt engineering to be efficient for a clinician to go type into the generative AI what they want and then print it off to use in their therapy session or a parent at home. However, if you look at this slide, and I asked ChatGPT for a list of 12 toys that might be popular with autistic children aged 8 to 12 years. So after 4 prompt commands, sort of trying to refine it, which was to replace items that were actually not toys that were in the list, what ChatGPT-4 had done was introduce therapy items instead of toys. So by the time I get to the 12 toys, I can quickly use that list to make my own visual display with the pictures using my other software. So in this case, generative AI can actually do a lot of the legwork of thinking of these things to actually creating the visual support that you want to, for example, to help people make choices about the toy that they want to use that day. So this is how the therapist and the AI work together to make to be more productive, to have more timely interventions, so that they get things just in time. So I'll go through now some pretty exciting developments in generative AI that relate to the speech aspect. One of these is called Quick Pick AAC, which is, I think, the first app that you can get that does use the AI and the computer vision through the iPad. What it does is you take a photo of a scene, and then the generative AI will create a list of topics that can be discussed when the child's looking at the photo of the scene. And you've got the topics and you've got the little pictures that are the vocabulary to use in the discussion of the scene. So this saves a lot of time for people programming those topic displays to help a child's conversation and to help them talk about, say, the scene that they took a photo of at the beach or wherever. So that's one example where we'll see a lot of growth in this area, because there's a lot you can do with helping people understand and to communicate. Another one is Vocal ID, which is about, you might have heard of this company, where it's around collecting voices and synthesizing a voice for a person who has no speech, or they use a speech generating device. So the problem that this one's addressing initially was that loss of voice or speech through motor neuron disease or cerebral palsy or other issues. And what it allowed people to do was to create a synthesized voice that could be used on a speech device. So it could be in their accent of their home, or it could be in the language that suited them, in a type of voice that they wanted to have. So this was really important for identity of people who don't have a voice. However, the company now using AI is doing a lot more with this so that everyone can create their own voice, using their voice in dubbing, in videos, in talent, in terms of, voiceover artists. Will it replace the work of voiceover artists is another question. But the cost and time saved in terms of getting that voice output for communication, and we know that some people need the voice output to understand the words, and reading the text alone won't be helpful for them. They'll actually need to hear the text being spoken. So that's vocal ID is one. Another one, an Australian one, which came out of Sydney University with Professor Kiri Ballard and her team, is Say 66 and one of their games, Say Bananas, where it's designed to help the child at home with their speech therapy, and the computer can hear and analyse the sound of the child's speech, and with the parent able to assist into the, in the interaction. They've done quite a bit of work with advancing this issue that children advance much faster if they have more practice of those speech sounds and the language that they're using. But to have feedback just in time that tells the child, yep, that's correct what you said, or nope, you try again, here's another one. That's something that helps children get that practice every day, which can help them to actually move ahead with the goals. So it's another example. I already mentioned briefly about our role in swallowing difficulty and the use of AI in the assessment and diagnosis of dysphagia, which is swallowing difficulty. So there's a recent review of studies outlining how the AI is used and how it could be helpful for the understanding normal or typical or expected swallowing, and helping in that diagnosis of identifying and reading the instrumental assessment results so that we get more reliable measures. And another important one is Google's Project Euphonia. Now, this will really advance the use of speech recognition of disordered speech. So people who have a different accent or who have a speech impairment, say through Parkinson's disease or Down syndrome or cerebral palsy, motor neuron disease, as they've pictured on the picture here, what this technology will do is improve the recognition of disordered speech so that the smart speaker or the device that's using the AI will understand that speaker and could potentially respond and follow instructions from that person, and could potentially translate their disordered speech or their impaired speech or speech with an accent into speech that the other people in the room need to understand. So I think that's got huge implications for the use of the conversational assistants. So we know that conversational assistants are already showing promise. There's research already around use of, say, the Amazon Echo and other devices for adults with intellectual disability, autism, and with working with speech pathologists and in residential supported accommodation to help them with their learning of social skills and to help them with their independence. So that's one way I think it will enhance. Another one is around an area that I've done a lot of work, is around mealtime assistance for people with disability, improving the skills of support workers and family members and people with swallowing difficulty. So one of the issues that happens at home for people with these difficulties is that implementation of texture modified food. So they might need their food to be soft and bite-sized, minced and moist, or pureed. And what happens is that they have trouble implementing it because there's so many changes to their diet, and they might miss what they enjoy. They might miss the flavors, the tastes, and the food that they usually had, and now they're on this new diet, and it's difficult for them to maintain. It's also hard for support workers to understand and implement such texture modifications if they haven't got a lot of experience with cooking, and if they haven't themselves needed to be on a texture modified diet. So I asked generative AI to make some pictures of a digital assistant in the kitchen helping a support worker and a person with swallowing disability to help them, and it came up with these, it imagined these pictures for me, whereby there's a third party in the room that is trained on nutrition, on texture modified foods, on mealtime assistance skills and behaviours, and that is there as an assistant in the location, potentially reducing safety incidents and improving quality of life and nutrition. So, you know, it would be good to see further investment in this. Could the AI and the conversational assistants help the therapy transition from hospital to the home and in the rehab setting, so that we've got interventions that are integrated across the care pathway? And the AI, of course, will help the learning that can go on with augmented reality, virtual reality, and simulated learning. So it would be great to see how we can use AI to increase the authenticity of our teaching at the of health courses, and also our assessment, so that it's authentic assessment and that we know that our clinicians are competent. There is a lot of junk AI out there. If you want to see instant AI apps like there used to be, there's an app for that. Well, now there's an AI for that. So I did find a virtual speech therapist that is Jessica, the speech therapist. So I think it's really critical that we get our evidence and our credibility up. Now, there's a Trustworthy Digital Society at UNSW and UTS. You can contact me and be in touch about that one. I think the trustworthy aspect is really speaking to that evidence and also having guidance. So regardless of what evidence is there, what would be the guidance? And I'm just putting up the contact details again if you would like to join in with our community. We're all trying to, as I said, catch up and keep up with these advances. So that's the end of my talk.
Thanks very much, Bronwyn. Fantastic, and fantastic range of speakers we've had today on very diverse topics. Really appreciate your time. So we might kick off with some questions. So I'd like to kick off with the first one, which is probably more directed to you, Trish, if that's okay. So you talked a lot about the traditional hierarchy of evidence that dominates, and I'm just wondering about how you see the task of changing perceptions in this space. So changing perceptions towards the different forms of evidence that actually might be more appropriate in different circumstances. So how do you see that challenge, and what can we do to tackle it?
Yeah, it's a huge challenge, and we have written, I didn't put this in the talk, but we've written in the social science literature about the links between knowledge and hierarchies of evidence and power. And I should imagine most people watching this will know that when you send your paper to a particular journal, or when you send your grant application to a particular panel, it really matters who reads it. It really matters who's on the panel, who's making the judgments. Most people operate in good faith. Almost everybody operates in good faith, but they are part of what we call an epistemic community, which says, I had one of my postdocs turned down for a grant the other day because they hadn't identified a very particular outcome measure that they would measure before and after a particular intervention. And that was just an assumption that the panel had, that really it didn't matter how complex the intervention was, you still had to do this very linear positivistic before and after study and show a kind of statistically significant change. So that's just one example. And there's nothing you can do if that's what the panel believe, because they've got the power. What you do have to do is get your people on the panels. And you also have to put a lot of work into selling the idea, into crafting the arguments, into marketing the ideas. And I spent quite a lot of time doing that. But recently, I simply got a grant to sort of pursue this sort of EBM plus idea. And I was really surprised to get that money, because I tried to publish papers on it, and the journals were saying, no, you're doing it wrong. Of course, we're doing it wrong. We're doing something new. But actually, because it was an interdisciplinary panel and it was looked at by philosophers, historians, people from outside the medical measurement community, they immediately saw as, oh yeah, well, this is how we might actually move the needle. So it's not easy. It's a contact sport. But just because you've got a good idea, it doesn't mean anyone's going to take any notice of it. And I think that the questioner knows that's why they're asking.
And you're getting some sympathy for the challenge in the chat as well, Trish. I'm not sure if you're following that chat, but really interesting.
I'm just
challenge.
looking.
Yeah. I guess I've got an extension from that question that probably speaks a little bit to both your presentation and Julian's. Like, Julian also talked about the need for having a dialogue or an ongoing conversation with decision makers, which speaks a bit to what you're saying, I think, Trish, about turning the kind of views around about the different levels of evidence and what they might want to access. So I'm wondering about,
absolutely.
I'm wondering particularly about the capabilities that you think need to be strengthened. So capabilities within perhaps the decision-making community to be part of that conversation, but also capabilities within the research community to effectively engage. I'm happy to throw it to anyone, actually. Do you want to start, Trish? Yeah.
Yeah. So I'll give you, I like stories. I'll give you a story. One of my PhD students, very bright guy, went into his Viva, and he came out and he said, they've passed me with no corrections. And I said, oh, that's great. And he said that the examiners said the reason why they passed me with no corrections, they said, was not because you knew everything or because you got it right, but because you were humble. And I thought, that's fantastic. What we need is more humility. And in my experience, if you're dealing with a group of people who think differently from you, but they are humble, and you are humble, you can make a lot of progress. I think the thing we need to expunge from our academics as they're developing is the idea that the higher they get, the more arrogant they should become, and the more sure they should be that they're right. If we can continue the humbleness, the humility, I think that would take us a long way. Anyway, I'll pass on to someone else.
Yeah. Julian, do you want to respond to this topic as well?
Yeah, I think you're asking about capacity, but in academia or on policymaker, or both?
I think when you talked about the ongoing conversation, the dialogue you need to have with policy agencies to make the synthesis relevant and timely, I'm just wondering what your reading is of the capabilities of the decision makers to engage with that, and also the capabilities on the research side to interact productively. Yeah.
Yeah, I mean, I think, again, we have to be humble, I guess, in understanding the context of decision makers. And I mean, of course, I'm sure a lot of people on this call live this and know that, you know, they're working in very challenging environments. There's very brief opportunities, brief, fleeting and limited opportunities sometimes to engage deeply with research and research evidence. And I think, as I mentioned at the end of my talk, I don't think we've really provided them with what they need yet, really, at scale. I don't think we've develop systems that at scale can really bring together, whole bodies of research and data in all these different and complex forms, can do it rigorously, can do it dynamically, can really move at the speed they need to move. And so I think, so a couple of things in terms of capacity. I think obviously what's important are those that are connected to decision makers, who is sitting at that kind of last mile of the research into decision making. So those that are within government, outside government, in other groups that are well positioned to play those kind of classic intermediary brokering kind of roles. And I think we've got to understand that is it's a profession. It's a very specific task and set of capabilities, and that often, my view would be that often academics are actually not well placed to play that role. Academics, at least sitting in the academic, I would say Trish might be an exception to this. You're so engaged. But often the academic incentives don't drive behaviours towards the kind of behaviours that are needed to be an effective broker with policymakers. So you can be very independently minded and perhaps break that mold, but that's more the exception than the rule. So I think we have to understand that as a very distinct set of capabilities and skills, and really build that both within government and around government. And then on the researcher side, I think I put in the chat, I think it's perhaps also having the humility that my own research is not the only game in town. That actually what decision makers need is a very broad and diverse and complex set of information and data in order to inform their decision making. Again, just a very quick anecdote. During COVID, there were some groups within Australia running, really, very, very impressive global platform trials. They had some outputs from that were very significant. We used that within the National COVID Task Force. Our recommendations were different to the findings of their trial. And, the researchers there were completely humble in saying, no, our job is done. Our job was to produce those data. And we understand that it has to be combined, of course, with other studies, other forms of evidence, in order to then make those kind of recommendations and decisions. I think that's the kind of, I would say it's a more sophisticated view of the role of researchers. And I think, unfortunately, some of the incentives that are being built within universities to demonstrate translation are driving, unfortunately, the incentive is to drive researchers to try and advocate for their own studies. Sometimes at the exclusion of the kind of the broader body of research and data that needs to be used.
Yeah, fantastic. So I've got a question about AI that probably goes to both Bronwyn and Julian. But of course, the aspirations for AI are enormous. Every time you turn around, there's a new potential application for AI that's being flouted or promoted. And you both talked about some of the risks that the application of AI methods done poorly can generate a lot of unintended outcomes. And I'm just wondering if you'd be able to share a bit more about how you think about that type of risk. Like, do you expect us to be suffering from a deluge of so-called insights generated from the AI methods that are out there that are meant to play into health service delivery, perhaps to pick up your presentation, Bronwyn, or even into the way evidence might be synthesized, and leading to a sort of a lack of confidence in AI as a method itself? Like, how concerned are you about that? And what, you talked a little bit about some of the safeguards, Bronwyn, that might be out there, but do you want to say a bit more about that as a risk?
I think AI is already being used in clinical situations. So the free versions, the subscription versions, the whole mix of it, that people are already the uptake and use is already happening, but there's such a lack of training and knowledge from, well, how can they use it safely? What are the safeguards? What are the guidelines? What are the considerations? I think we need to increase the capability of the workforce. And it's going to be with AI with the clinician rather than AI instead of a clinician. So I think that's where the safety is going to be, that the quality and the usage of it, the safety of it, whatever they're using it for, that it be rigorous and it be helpful for the situation, even if there aren't treatment studies on that technology, that they know how to evaluate it themselves and that they know how to critique the outputs and they can detect the level of accuracy, and then they can decide, will I use this? Is it accurate enough for the situation? Or are the stakes too high and I'm not willing, I can't use it yet? So I guess that'd be my main point, that we need clinicians to be able to judge and be involved.
Yeah. Thanks, Bronwyn. And Julian, in relation to evidence synthesis itself, I mean, you had a slide that had the science of Twitter written up on the screen. I mean, what do you think about the risks here about the way AI could be used to poorly synthesize, poorly try and mobilize different evidence?
Yeah, I mean, again, as Bronwyn said, it's kind of with us now. So we've always had many different types of kind of quick and dirty approaches to try and make sense of research. You know, a staffer calling a leading scientist a senior arrogant researcher, as Trish would say, is an example of that. Those kind of quick and dirty approaches, and I think these products, whether they're kind of general purpose or more specific, are with us now, being widely used and kind of just the next version of that. So that's definitely going to happen. I think that's you know, the tools will get more sophisticated. Again, the actual performance will lag the claims. And so I think that actually the next few years in this kind of world of using research evidence in policy and practice is going to get very messy. As an anecdote, so you know, I was a few months ago meeting with an MP in the UK in London, and you know, the first question is, well, why do we need these evidence systems at all? Like, don't we just use GPT now? And I think we're going to hear a lot more of that. You know, I think I'd be highly confident in the prediction that any of us who are, you know, working at this kind of interface are going to increasingly, you know, as the products become more sophisticated, more slick, you know, as it literally will be like, you know, remind me why we should be funding your institute. Given that, you know, the technology can just do it now. You know, my staffers are using them all the time. You know, they're fantastic. They give me an answer in half an hour. So we you know, we need to get our act together pretty quickly, I would say, and, you know, demonstrate that we can, you know, provide value and be very clear about the distinctive value. And also, of course, you know, as Bronwyn's been emphasizing, you know, there's a lot of potential with these technologies as well. So we need to look at essentially rapid, safe, and responsible use of these technologies.
Did you want to comment on this, Trish? I'm interested in your view about the messiness of the environment that we're heading towards that Julie's describing.
I mean, I'd say one quick thing, because I know we're up at time. I recently went on a proper course run by AI experts about AI, particularly generative AI, large language models, but also the kind of more statistical stuff. Well, I mean, it's all statistical. And it was only after doing the course that I fully grasped both the huge potential and the massive limitations of these tools. So, and it was a difficult course. I mean, I didn't kind of take to it intuitively, but I would strongly encourage people to go and do a course, and then you realize this stuff comes out really plausible, but it hallucinates, and it probably will continue to hallucinate, all that kind of thing. But you know, book yourself onto an AI course, and then come back and think, now how does that fit in with what I'm doing, say in relation to evidence synthesis?
Thanks, Trish, and you're right. I think we are pretty much out of time. So I might hand back to Ian. Ian, are you able to? Yeah. Okay.
Yes.
Over to you, Ian.
Well, look, just remains for me to thank Trish, Julian and Bronwyn for the breadth of their presentations and the highlighting of the challenges. I think you've finished up on the major challenge. These fields are working developing so quickly, we're having trouble keeping up with them, I think, and unfortunately they sometimes get utilised before we've worked out the ethics of it and whether they are going to actually be an advantage. I'd also like to thank all of the members for attending this and for their comments and questions in the chat function. I reiterate Martin's comment that we'd like to hear from you about future topics that you'd like for these forums, and so we're always keen to hear from our members about things that they'd like us to put a group of expert speakers together like we've had today. So thank you very much. We'll draw it to a close and we look forward to a really challenging future here. Thank you.
Thanks, everyone.
Thank you.
Thank you all.